That's all right. And everybody's getting the message that we're recording right now. So everybody has to push the little button on their screen so they can keep moving forward. Anyway, so welcome to the May EQIP meeting. And just to remind you, our next meeting will be in July. And we'll send out an invite, but you should already have it on your Outlook calendar. If you're not getting emails on the EQIP, please let Barbara or myself or Jessica know, or you can email the crisp email address, any one of the three of us. I just want to make sure everyone's getting it. You know, I know sometimes stuff goes to spam and everything from an administrative view. Before I turn it over to Jessica, I did want to let everyone know, I don't know that we've spoken since the General Assembly session ended. For those of you who are interested, or for those of you who were not paying attention, MedChi, Care First, and the hospitals came to a consensus on the value-based care legislation. And MedChi has put up on its website information about the legislation. If you go, and I put the link in the chat, and I can email it out as well, but if you go on our website, we have a copy of the actual final enrolled bill that was signed into law by the governor last week. We have a summary of the legislation, and we also have a 10 things you need to know on contracting. If any of you have any ideas or suggestions on additional materials we could put up there, I'm open to them. Please use them and share them. One of the things that I think all of us who've been working on EQIP for the last 5 years are very proud of is the fact that we do, and we have thought about aligning private payer value-based programs with this government program. I think that's a positive. It's a positive for physicians because it's hard for docs to change what they're doing from patient to patient based on what the insurance is. It's a positive for simplicity, and it just makes it a more coordinated and organized effort. So hopefully this legislation will allow that to happen as well. And some of the concerns that particularly the physician community had about risk got resolved as well through the course of the negotiations. So I think we ended up with a product that was pretty good, actually, and I'm excited about the future around that. So I wanted to start by just kind of giving an overview and talking about that. If you have questions about it, you can reach out to me or someone at MedChi, or you can reach out to your respective organization, and we're happy to help and talk. So having said that, I will turn it over to Jessica for the May EQIP meeting and let her kick it off, and we'll go from there. So Jessica, the floor is yours.
Thanks, Gene. So I just have a real quick update from an administrative side for our participants for year one, and then I'll hand it over to Will, who will do an update about next year, including final episodes and policy decisions. And then we'll end our meeting with a talk about a resource guide that we're calling the EQIP Toolkit. So just real quick, as a reminder for those that are participating in performance year one, our CRP entity is that sole singular hospital. It is UMMC, and they serve in that administrative role of signing the care partner agreement with all the care partners, and they are ultimately the ones that pay the incentive payments in the following year. So just as a note, in preparation for the payments going out in 2023, UMC did send an email and requested all entities to send a W-9 so that they can get that entered into their internal system. Just as a note, we do realize and apologize that the initial deadline or turnaround time request was quite short, but we did extend that. So hopefully you are able to return that to them by May 31st, the end of this month. And then please, if there are any questions related to the W-9, the CRP entity has this inbox, the equip@umm.edu, and please direct questions there. Of course, again, feel free to always contact any of the three of us or the other EQIP inbox, and we can direct you as needed as well. So that's it from the W-9/CRP standpoint. Yeah. If there aren't any questions, I will hand it over to Will.
Thank you, Jessica. Would you mind going to the next slide, please? We wanted to do a very brief update on our performance year 2 episodes. So we've been working to incorporate suggestions from physicians on what episodes would be most valuable to add for a following year. And we've decided that we're going to finalize adding all of the ED episodes proposed by the ED physicians, in particular, Dr. Jesse Pines, who we want to thank for his work and his suggestions, which have been very good here. We did find that there were 2 ED episodes as proposed that did not have enough volume to be viable. That's the hypertension and the hyperglycemia without diabetes. So we will not be including those. However, the remainder of the episodes we will be adding, and I'll show them on the next slide, next couple of slides. Additionally, we did decide to go ahead with including only the relevant costs as proposed by the ED physicians. And again, a big thank you to Dr. Pines and his team, because I think that was very helpful, providing the clinical expertise on what should be considered a relevant cost to an ED episode. Additionally, we're adding some more Prometheus episodes for allergy, dermatology, ophthalmology, orthopedic surgery, and urology. Just as a reminder, we drew, sort of a rough mapping between the episodes and what specialties we think are most likely to perform them. But there are a lot of episodes, such as UTI, for instance, that are performed by other specialties, internal medicine, et cetera. And so just a reminder that there is no restriction on which specialties can participate in which episodes. Any specialty can participate in any episode, so long as they perform enough of those episodes. So obviously, a urologist won't perform enough orthopedic surgeries to be able to participate in those episodes, but an internal medicine physician could participate in the urology episodes, for instance. These include some procedural episodes, which we're all very familiar with, as well as some chronic episodes and complications episodes. We're going to talk about those chronic episodes a little bit later in the slides, because we need to do some tweaks to the overall EQIP program for that. But the rest we're going to add, and folks should be pretty familiar with those. We're happy to provide a list of codes for the triggering diagnoses and the relevant cost to any interested physicians. If you would like a copy of those codes, please email equip@crisphealth.org. Next slide, please. So this is a list of the Prometheus episodes that we're adding for year 2. And you can see the sort of rough alignment with the specialties, and then whether they're chronic, complication, or procedural episode. Next slide, please. These are the ED episodes that we're finalizing. And so these, as a reminder, are triggered with a relevant diagnosis code and an ED visit. And then they're attributed to the MPI that performed one of the triggering conditions. I'll stop there, see if there are any questions before we go on to the chronic episodes and talk about those.
So the one question I did want to ask was, and obviously we are requesting that CMMI approve all these, so I don't think there'll be a problem there. And that is kind of my first question / comment. And then my second question is if for some reason we have a group of docs who say, hey, I really want to do another one on Prometheus, are we too late to add it into the request to CMS?
Yes, to the second question, but we're happy to continue adding additional episodes in future years. So there will be an opportunity to have those added for 2024 and beyond. Sorry, Gene, what was your first question?
First was kind of a question comment, but these are subject to approval by CMS, obviously, but I think we're pretty comfortable that these are all going to be approved, correct?
Correct, yes. So 95% confidence.
That's pretty good. All right.
And Will, this is Jesse here. Just a quick question on the timing of getting the target price. I know when that's going to come over.
Yeah, so we have run the target pricing for your group, and we're happy to meet with you to walk through those results. I think for others, we will provide the target pricing as part of the regular enrollment process, and that will be available in the fall once the application portal is up and online.
Okay, thank you. And a second question, I know that CMMI just released some strategy around where they're sort of moving away from specialty specific payment models to something that would be sort of more nested within, within an ACO. How does that affect these models, or does it at all?
Yeah, so we don't anticipate it affecting us. I think the way that I would view this model, if I were still sitting in CMMI, is that this is a program that's nested within a giant ACO that includes all of the state of Maryland. And so I think it's pretty consistent with their strategy. Obviously, a statewide ACO concept is different from your regular MSSP programs, but I don't foresee a problem, with their strategy. And it's the right strategy. Now going through a couple of different CMMI strategies, and like you meet the new boss same as the old boss, right? I don't think that there would be a change of course for us.
Okay, thank you.
Any other questions or comments here? Great, wonderful. So during the previous work group meeting, we had talked a little bit about the potential of overlaps between episodes. So as a reminder, this would be if somebody triggered an ED episode and then triggered a procedural episode within the same time period. That raises the possibility of double counting savings, and that's problematic from a statewide perspective. If $1,000 are saved, but we count that for 2 different episodes, we would end up paying more than the savings that were created. We were considering a bunch of policies to correct for overlaps between the 2 episodes, but in doing the analysis, we discovered there really wasn't enough overlap for us to be worried about in the procedural, and that should say complications or ED episodes. In the chronic episodes, we do think there needs to be a correction that's made, and we'll talk about that on the next couple of slides. But in general, for the ED episodes and the procedural episodes, it's possible there will be some overlap, but it's not large enough for us to really worry about. So in the chronic episodes are a little bit different from the procedural episodes. So the chronic episodes are things like glaucoma, lower back pain, etc. These episodes have a pretty long episode window, and they don't have a clear procedure-based starting point. So, for a surgery or one of the other procedural episodes, there's, a clear event that starts the episode. Somebody with lower back pain, there's no clear procedure that starts that episode. And so it's difficult, A, to know when the episode begins, and B, to attribute it to the right physician. And so this means that we have to use slightly different attribution rules. And then secondly, since the episodes tend to be very long, there's a high probability that they're going to overlap with some procedural episode a little bit farther down the road. So we're going to talk about 2 things that we make for chronic episodes. The first is that we're going to attribute the chronic episodes to the MPI that provides the plurality of office-based E&M codes during that episode. I consider this to be a little bit, this is necessary, but it's suboptimal, right? Basically what it means is that if we have lower back pain over 180 days, we're going to attribute that lower back pain episode to the doctor that provided the plurality of care during that 180-day period. So I'm just highlighting that because unlike a procedure-based episode, you won't know whether an episode is attributed to you until after that episode completes. If you sorry, go ahead.
Fix ना आता तो कहीं वहाँ तो नहीं इंस्पेक्टर ने आवाज दो एक्सेप्ट प्रॉब्लम कवर पड़े तो we can.
I think that was not for you. I muted.
No, that was not me. Wonderful. Thank you, Gene, for complimenting my lyrical references. So just as to recap, we attribute the episodes to the MPI that provides the plurality of care during that episode. That means that the physician that's sort of most responsible or has the most touches with the patient will be accountable for that episode. But we just want to highlight there the difference between this episode and a procedure-based episode. In a procedure, an event happens, a physician does it, who is the episode is attributed to. Okay, so second issue we have with chronic episodes is the possibility that over 6 months or a year of lower back pain, that patient is going to have another type of episode, a procedure-based episode. When that happens, that raises the double counting issue that we just talked about. So our solution to that is going to standardize the cost of any downstream episodes that occurs. The intention here is to allow the initiating physician to get credit for avoiding an unnecessary procedure, but then to, if the procedure occurs, attribute any episode costs of that procedure to the physician that performed the second episode. So that's all very complicated. So we're going to talk about that a little bit more on the next slide. Please, Jessica. Thank you. So I've done a visual explanation and then a verbal explanation. So in the visual explanation, a chronic episode is attributed to a physician on the left-hand side. That physician is responsible for managing all costs that occur during an episode, and they get credit for and potentially savings for managing the episode costs and avoiding downstream procedures. If a downstream procedure occurs, we're going to treat that episode as though we're buying the cost of the downstream procedure at a standardized price. If the actual procedure episode is well managed and it comes in below the standardized price, we are going to give credit for managing the procedural episode to the physician that performed the procedural episode, not the physician that is performing the chronic episode. So in other words, the physician doing the chronic episode gets credit for avoiding unnecessary procedures and managing non-procedural episode costs. And that if a procedural episode occurs, the physician that performed that procedure is then responsible for managing the costs related to that procedure. So again, pretty complicated. I'm going to try in a verbal example on the next slide, please. So here we go. Suppose a physician is attributed a lower back pain episodes. These frequently overlap with lumbar laminectomy episodes, so we potentially have a double counting problem. A quick note here, I've made up all these numbers. They bear nothing to reality, so don't rely on them for anything other than this example. So suppose we set a standardized price of $12,000 for each lumbar laminectomy episode. If the patient has $8,000 worth of non-lumbar laminectomy costs, and then they also get a lumbar laminectomy, we add the $12,000 from the lumbar laminectomy to the $18,000 in non-lumbar laminectomy costs for a net episode cost of $30,000. So if the target price is equal to $30,000, they haven't generated any savings, but they could generate savings by doing one of two things, either by reducing non-lumbar laminectomy costs or by avoiding the need for a lumbar laminectomy entirely. However, if the lumbar laminectomy occurs, we're going to set a target price for the physician that performed the laminectomy at $12,000. And if the cost of performing that procedure come in at less than $12,000, the credit for those savings go to the physician performing the laminectomy, not to the physician managing the chronic lower back pain episode. I'm going to stop there, see if there are any questions, because that was a little complicated.
Yeah, well, I have a question. This is Daniel. How do you guys, I mean, I'm sure that you guys have algorithm doing it, but how do you determine whether something was successfully avoided?
So, the way that this basically will occur is that each physician is going to be get a target price based on their historical costs. So if, let's say, there are 100 lower back pain episodes attributed to that physician in the baseline period, and 20% of them have a lumbar laminectomy, then the target price that they get is going to be the average of all of those episodes. So it's going to be a target price that's based, that has 20% of the episodes, including a lumbar laminectomy cost. In the performance period, if the physician has fewer than 20% of their lower back pain episodes getting lumbar laminectomy costs, that's going to count as an avoided lumbar laminectomy. So If in the baseline period 20% had the laminectomy, in the performance period 10 did, then we would say 10% of those episodes avoided an unnecessary lumbar laminectomy. Does that make sense, Daniel?
Yeah, that makes sense. Thank you.
Wonderful. Any other questions?
Daycare for both of them.
Hey, Will, it's Adam. Good morning to you.
Good morning.
I wonder if you would like to comment or just sort of consider the so the pattern you just described. It seems like it might mirror similar patterns taking place generally in the marketplace unintentionally. Is there some sort of way to address that? So if there's a lowering of those kinds of procedures in the general population that somehow coincide with that same reduction from your 20%, what does that look like?
So in general, we are not going to make programmatic adjustments for that. We in general want to encourage sort of the Maryland in particular to follow or beat the rest of the nation in reducing or, sort of right sizing where services take place or whether they're necessary or not. There might be specific adjustments that we need to make to particular episodes. So for example, if a service stops being covered by Medicare, those would all show up as an avoided service, but really it was a coverage decision that Medicare made and not a care practice of care change that happened. So in general, we are not going to make adjustments for secular trends. There might be episode specific adjustments that we make in the future. And then secondly, while we've said we want to maintain a consistent baseline for as long as possible, to give you credit for, sort of cumulative changes that occurred over time, it may be necessary to update baselines due to secular trends, et cetera, that we should not continue granting credit for into the future. Does that make sense, Adam?
That makes sense. Thank you.
Hey, Will, this is William. Just to add one more comment, there is also the sliding gain share feature of the program also slightly impacts that, right? Because a secular trend is pulling the average improvement. You would, to get the maximum sharing, you would need to beat that secular trend over time within the Maryland program.
Yep. Thank you, William. Very good point. Other questions? Okay, fantastic. So when we talk about a standardized cost for an episode, we have a couple of different options here. The easiest option for us is just to replace the cost of the lumbar laminectomy with the statewide average cost of that procedure. This basically holds the physician who has attributed the chronic episode harmless for any variation in the procedural episode costs and gives the credit for savings within the lumbar laminectomy to the physician that performed it. That being said, there are cost differences that the physician managing the chronic episode might be able to control. So for example, if there's a big difference in cost between a service provided in an ASC or hospital outpatient department, encouraging a patient to get a service in the most cost-effective setting of care is something that the chronic physician could, or the physician managing the chronic episode could potentially do. And so we are considering setting the standard cost based on the physician or facility average of the rendering physicians instead of using the state average. So this would allow physicians who are accountable for the chronic episode to earn savings if the procedural episode occurs in a more efficient setting of care. But then if within that setting of care, there are savings, that would still go to the rendering physician. So our preference is to use the latter approach, but there's some data and reporting issues that we need to walk through Namely, if we were to do this at a physician level, there are going to be physicians that don't have enough episodes for us to generate a standardized price for them. And so we have to figure out some analytical approach to handling that. Once again, I'll stop, see if there are any questions on that. Okay, seeing none, that's it for year 2. Once again, a big thank you to Dr. Pines and his team for helping us to develop, or actually developing entirely, the ED episodes. And I think it's a good example of how we can partner with the industry in the future. So if there are episodes that you're interested in doing that are not on the Prometheus list currently, and you have an idea for which episodes you'd like to do in the future, please let us know, and we'll be happy to work with you to develop those and include those episodes going forward. So once again, thank you, Dr. Pines, and to everyone else, please let us know all of your clever ideas that we can include in this program.
Hey, Will, I have a quick question. Has anyone brought up about episodes for oncology or hematology, or sorry if this was already been discussed with the group?
Yeah, so we've discussed oncology episodes on and off with this group. I think we would be open to suggestions there. So if you have an idea for an oncology episode, we'll be happy to include those. That being said, I personally think that oncology episodes are the most complicated episodes that we could possibly try to design. The episode costs varies very significantly with what medication the patient is eligible for. With some of these new wonder drugs coming online, a patient's episode cost could be very different if they have a different genetic marker, for instance, and that makes it extremely difficult to set a target price for those. So that's not to say that this is impossible. I think we'd be very happy if you had suggestions on an oncology episode and how to construct that and what costs should be included, what costs shouldn't be included. We'd be happy to work with you. It is, a warning, which is, we will need a fairly well-designed episode. I think, we wouldn't just be able to say we want to add breast cancer and then take it from there. We'll need a lot of clinical expertise from your side to be able to develop that effectively.
Thanks. Well, just a question, actually, Jason posed it. This is Jesse here in the chat about any additional hospitalist medicine episodes are going to be added for 2023 beyond AMI hip fracture.
So the list of the episodes is that we showed earlier are the ones that we're adding for 2023. If there are additional ones that you'd like added for 2024, we'd be happy to add those. And as a reminder, there are a number of year 1 episodes that are also still available to any new participants.
Okay, thank you.
And I would just say that one of the things that might make sense is, and we have some specialties where I think there might be some opportunity, it might make sense to have a call with a specialty to have a discussion, and it seemed to me that we should have been able to work out something on ENT, and there are a couple others where I think there might be opportunity that we just either haven't had the interest from the physicians or we haven't been able to get to. So if there's a suggestion or an idea, we're open to it. And I would suggest, even if the idea is around the list of Prometheus, reach out to us now so we can start doing the work now and dealing with the details, and it'll make it easier for the following year. Will and Jessica and I are happy to have specialty specific calls and work through the issues and try to figure out how to make it happen.
Wonderful. So if there's no other last minute questions, I'll turn it back over to you, Jessica.
Okay, thanks, Will. So we actually are running through this agenda pretty quick, but our last agenda item is actually, we're going to cover what we're referencing sort of as the EQIP Toolkit, which our colleagues at the American Institute of Research, AIR, will actually present on. So basically, acknowledging that EQIP is a new model to many participants, Chris actually contracted with AIR to identify strategies, best practices, etc., identify areas of quality and efficiencies within episode-based payment arrangements. and to create sort of a resource guide. So with that, let me turn it over to Liz Gibson and Emily Elstad, who are two researchers from AIR, and they'll talk a little bit about the process. And of course, we'll share the end product as well.
Thanks, Jessica. Hi, everyone. I'm Liz Gibson. I'm a health policy researcher here at the American Institutes for Research, and I'm joined by my colleague, Emily Elstad, and we're going to walk through the best practices toolkit that we developed for you all. We'll start off just with an introduction about what this project was for us, discuss the search criteria and our approach, and then go from there. So we began working on this in February at CRISP's request. They wanted us to do a literature scan of publicly available resources, both peer-reviewed articles and then gray literature, to help identify best practices and strategies for successfully participating in an episode-based payment arrangement. And then based on that scan, we developed a toolkit for you all that highlights some of the key lessons learned and really narrows into a few key resources. Our search strategy for the literature scan was to focus on more recent resources. We did go back all the way through 2012 though, but really tried to focus on the past 5 years, going back to the past 10 years. We wanted to make sure that what we pulled was relevant for all of you. So we tried to find resources on cardiology, gastroenterology, and orthopedics when possible. And we wanted to make sure that we included resources from a wide variety of sources, both peer-reviewed journal articles, but then also looking at professional associations, state and federal governments, and healthcare industry news sources. During our initial literature scan, we identified 81 potential resources, and then we narrowed it down to 26 core items, and then there are, I think, 5 additional items on top of that. So the 26 core items, we wanted to make sure that, first of all, they were all publicly available. The 5 additional items are behind a paywall, but they were for common journals that we imagine some of you probably have access to. So for those 26, we wanted to make sure we were looking for resources that had very clear recommendations and actionable lessons learned directly from providers who had participated in episode-based payments. We wanted to make sure that what we included was as useful for you all as possible. We looked for best practices around episode-based payments, but then during the search, we realized that quite a few of the resources mentioned both building consensus among healthcare workers and using time-driven activity-based costing. So those are 2 sub areas that we pulled out more introductory 101 resources on that were not specific to episode-based payments. And we wanted to make sure that we included a variety of formats. So we have clinical studies, but then we also have kind of more informal perspectives from industry leaders. So that can include blog posts, Q&As with doctors in the field, formal memoranda from professional associations, and then we have a few long form research reports. So there's like a 100-page plus report from the RAND Corps looking at episode-based payments. Some common themes for the toolkit. Of the 26 resources, to start off, 4 were on cardiology, 2 on gastroenterology, and 6 on orthopedics. I'm sure it'll be unsurprising to all of you that there was significantly more resources on orthopedics because of the CMMI models that focus on orthopedics. So both the bundled payments for care improvement and the comprehensive care for joint replacements. There's simply more comprehensive literature published on those 2 models. But we imagine that there'll be more and more articles and papers on bundled payments and other specialty areas as it becomes more and more common. Of that 26 resource list, there are also 3 that provide very kind of introductory material on episode-based payments. We wanted to make sure that we included a full breadth of information on bundled payments. 3 that offer insights specifically on gaining buy-in from healthcare staff. So those 3 resources may have some information on bundled payments or alternative payment models, but some of them are also just kind of more general. How do you build consensus among your staff? And then 3 are on using time-driven activity-based costing methodology. This is a methodology that came up again and again as we were reading through resources. So we wanted to make sure we included articles specifically on that methodology. So those of you who might not be as familiar with it can learn how to use it. And time-driven activity-based costing is essentially a way to determine the entire cost of care, looking at provider time, but then also resources used, diagnostic testing, everything included in an episode of care, and figuring out how to zero in on potential areas for increasing efficiency. 3 were on Prometheus in particular, and then 17 offered best practices more generally. And common themes among those best practices were investing in data infrastructure, developing care pathways, identifying patient risk throughout the episode of care, and fine-tuning discharge planning. So we wanted to make sure that we included articles that would be relevant for you, but then also for your colleagues that you're working with on this. And just to provide a high-level overview, 2 examples of resources in the toolkit are, the first we included here is from the American Medical Association, titled Transition to New Payment Models. This is about alternative payment models more generally, but it does talk about episode-based payments in particular. And so they include a 4-step guide for providers who are first implementing alternative payment models. And in those 4 steps, they break down into even further sub-steps about how you can approach this. So that includes things like creating a utilization budget with an exhaustive list of every single service that will be included in an episode, determining the volume and demographic information of the eligible patient population. They have some tips on how to work with the health plans involved to get information from the payers as well, and then calculating the total cost for each service and determining if the budget allocated for that covers those costs. And then kind of on the other end of the spectrum, we included here an example from the Harvard Business Review. So again, we really looked at a wide range of resources. And this one is much more informal, very short. It's called Getting Bundled Payments Right in Healthcare. And it offers a brief case study for a specialty orthopedic hospital and then a private practice physician group that successfully implemented bundled payments. And they have key recommendations from those 2 groups, including using time-driven activity-based costing. So this could be a good introduction for those of you unfamiliar with it. And then developing a comprehensive pre-op risk screening that will allow you to identify psychosocial risk factors that could impact the patient's outcome. So again, these are just 2 of the resources from our list of 26. We have a wide variety of resources, and Emily and I are happy to take any questions right now, or we can triage them to Jessica as needed.
Thank you, Liz, and thank you, Emily. Just as a note, so the final report is a PDF that I believe some of you had emailed, but we will make sure it gets sent out to the entire group as well as posted on CRISP website with the links as well as like a very brief 1-sentence summary, so you guys can go through it and select which resources you think may be applicable or valuable to your team. And then additionally, we hope to continue our work with AIR and build out this resource guide more and more. So after you all have a chance to look at it, if there are areas or specific questions that maybe the literature can provide some best practices to, please triage that to the equip@crisphealth.org mailbox, and we can work with AIR as we, like I said, continue and build out this toolkit as this program develops.
And I just also want to remind everybody that CRISP generously helped us create a 1-credit CME, which is available and live on the Beacon platform, which you can access through the CRISP website or the MedChi website, either one. So that's another great tool to kind of learn about EQIP specifically in connection with this. And it's also a good tool when you're talking to physicians in your group who maybe you signed them up and they're not quite 100% sure they can understand the why you're doing it. And I think whenever you explain people why they're doing something, they tend to do a better job doing it. So it's just another tool as we try to make sure we have all the educational resources available for everybody.
Great, I think that's the end of our agenda. So as Jean mentioned in the beginning, our next meeting is in July. I don't know the date off the top of my head, but we will make sure that's on your calendars and send reminders out. And then additionally, I think prior to that July meeting, the portal will actually open for year 2. So again, we'll ensure that communication is continued out before that meeting.
So Will and Jessica and I are doing a special meeting next week for dermatology. So if any of you have physicians who are dermatologists and would like to learn about the dermatology bundles, we are also scheduling meetings. We are scheduling a meeting with the allergist to do the some specific information around those bundles as well. That has not been scheduled yet. We're working with the Allergy Society to do that. If you're interested in either of those, you can reach out to me. I will send the dermatology information out if any of you have any connections in that space. We have already done meetings. Actually, we've done multiple meetings with ophthalmology, and we've done a meeting with urology. Those videos are available on the MedKai website. So if any of you are interested in the new bundles around those, let us know. And Dr. Pines is working with me to schedule an emergency room episode, a discussion, so we can do some education around that probably sometime in July and June. So again, if anyone feels like they want specially specific education, MedKai, HSCRC, and CRISP are happy to work together to make sure it's available. Will, Jessica, anything else for the good of the order? No?
Nope.
I don't think so. Our shortest meeting yet.
I know that's a record. You want to throw out any more good lyrics, to end the day with, Will? That was pretty impressive.
What is the Led Zeppelin song? The same thing over Ramble On. It goes on same day every day.
There we go. You're in a 70s mood today, I guess. All right, everybody. Well, thank you for participating, and we'll see you in a couple months. Enjoy your Memorial Day weekend next weekend.
Thank you. You too.
Thank you.
Thank you.
You.